take a couple of minutes this afternoon and welcome each and every one of you on behalf of the Social Science Research Lab to the Disparities in Health and Healthcare, exploring opportunities for collaboration between researchers and practitioners. I want to recognize and give a personal and professional thanks to each one of our panelists. We had some preliminary discussions about this thing. We've actually done a pilot sort of test of this last year, and we started thinking about people, and then in short order, the people around us knew people, and then the next thing you know, we get this super panel of folks that we have here. I'm so excited to listen to the discussion, to learn more about how, as a researcher myself, I can do better work to have a more translated impact on policy and practice. I want to, before I get going too far, just recognize and say that the event will be videotaped by Missoula Community Access Television as part of its media assistance grant program to nonprofit organizations. And I'm here to do the welcome. I hope you all feel very welcome to be here. We're thrilled to have you here on behalf of the University of Montana and this beautiful Gilkey facility that I just am in awe in every time I come in here. I want to transition now and just do a brief introduction to our Master of Ceremonies for this afternoon and early evening, Dr. Chris Comer, Chair of the College of Humanities and Sciences, has graciously agreed to be here to moderate the discussion for our panelists and of the panelists, and I'll turn the time over to him. Thank you, Chris.
Great. I think I'll follow you and not use a microphone. Can you hear me? Okay. Thanks for coming out this afternoon. This is a really exciting event. It's something I've been hearing about for well over a month, and it's got a really practical purpose. It's not just to have a discussion, it's really to get folks fired up and figure out what we can do in our community to really make a difference, which is something important. And when you get to the subject of health disparities, there's almost no way to overestimate the importance of that. It's really, really, really a powerful thing. So let me just say that they asked me to just let you know that health disparities is a difference in outcomes for segments of the population, often linked to social, economic, and environmental differences. Something that probably most of you already appreciate. And the purpose of today's forum is to examine how researchers and practitioners can work together to address the issues that come about in trying to solve health disparity issues. We have a truly distinguished panel. We're going to let them introduce themselves, and that'll be the first part of the program. And after those introductions take place, we will switch, and I will pose some questions. And those questions will come out of a report from the HHP, in which they outline some of the key things we have to be thinking about in terms of health disparities. And as soon as we've had some feedback from the panel on those questions, we're going to open it up so that you can ask questions. And I would say to think hard, ask good, tough questions. And I want to let you know that this is something that, if it takes root here, as we hope it will, it could be repeated. It's something we could visit and try to make Missoula a place, and the University of Montana a place where health disparities are taken seriously and some of the key challenges are addressed with lots of community partners across town. And last but not least, I wanted to recognize one person who's really gone full tilt to make sure that this happened, and that's Chuck Harris, sitting back there modestly, who'd never claimed any credit for it. Chuck is a quiet force of nature who makes lots of good things happen in the Social Science Research Lab and in the Department of Sociology. So we appreciate what you do, Chuck. All right, so I'm going to turn it over to the panel for introductions. Chelsea, do you want to go first?
Yes, well, I don't want to, but I have to. Hi, thank you guys all for being here. This is such an amazing topic and a great opportunity, and thank you for having me. Just going to spend a few minutes. I'll give you a little bit of my background, my circuitous path, and it will help inform, I think, some of the thoughts and perspectives that I might provide. Probably the farthest end on the, I'm probably the most practitioner-y of the panel. So you guys, I grew up in Missoula. I studied biochemistry at Bozeman. I got my MPhil in the economic and social history of medicine at Oxford before coming back to Harvard for medical school. I blame that experience very much on my inability to be sort of an arrogant, focused physician who has all of the right answers all of the time, because when I was at Oxford, I really had a chance to explore the time-bound nature of medical knowledge and the importance of sort of the ongoing feeding between the research community and the medical community, because without that collaboration, we would still be bloodletting or something while other options were available. I came back to the Northwest and did my pediatric residency at Seattle Children's, and I do also approach the world very much through a child health view. So sometimes what I don't know about the adult world, I will blame on that. Since that time, I've been in teaching hospitals. I spent some time in private practice. I've been at the Institute of Medicine looking at national reports on defining child health and healthcare quality in DC. And then I was the director of children's healthcare quality for a 25 clinic FQHC actually in New York that spanned taking care of vulnerable children from very different populations, from inner city kiddos to Hasidic Jewish communities to migrant worker families, and sort of trying to think about how we could understand our challenges and create best practices from the center there. And so my path is circuitous, but now I'm the founder of a healthcare technology company, and add to the perspective, sort of what are we thinking about in terms of the innovation world as well, which is not as much represented here, but is sort of trying to intersect with healthcare and research as well. But this is really where my passion lies. I think that all of the most important problems are solved at the meeting of disciplines, and that it's a challenge for all of us to speak each other's language, and to grapple and to find the useful truths together, so that we can make a bigger impact. But I think the biggest challenge for all of us in that is thinking about what in our own worlds are the traditional and the narrow definitions of success, and how do we transcend our own view of success in order to translate and work with each other. Because in research, that may be a publication, and for a practitioner, that may be our views. And unless we can sort of recognize and align those incentive structures, it's going to be very difficult. So, I guess I just put out there, I believe our challenge is not only for us to think about best practices and to establish those, but to challenge the research community to really also think about two more things. One is dissemination, and to think about how will I tell the world what I find in an honest way, and to even have the forethought to think about sustainability. Should we find something that is useful for the world, how will I be a part of making that a sustainable option? I have many more things I could say, but in preparation for our time tonight, I reached out to a couple of folks in our community, because I haven't been back in Missoula very long, and I didn't want to pretend like I could speak for some folks who are here. And I got some great responses from some women leaders in our community who are either looking at grant funding opportunities and who are CEOs of the Community Health Center here. And I wanted to share, sort of as a bit of a challenge, it's a little bit of a rough start, her initial reaction, what she sent before we move on. So I can be the good guy, but I think especially for all of our young and well-intentioned researchers, I want you to hear some of this angst. So she said, she started off saying, my exposure to sort of the intersection of research and practice is from the School of Hard Knocks. But somehow, she's talking about an experience not here, I thought these researchers, all of whom were really smart, wanted to improve outcomes. And ultimately, they probably did. But first and foremost and repeatedly, they wanted the NIH money to study and publish. The health centers, and especially the populations, were the rats in the maze, and it took me forever to figure it out. We kept trying to partner and have our programs studied. They wanted the resources to replicate the program we had begun, hire their own staff, conduct an experiment, and get it published before the next researcher. Once I understood we spoke a different language, it was easier, at least, to share ideas with them. They'd get a letter of support, some ideas, a bunch of money, and we would just keep on doing on-the-ground quality improvement. It's a bit of a rough start, but But I'm just going to leave you with that piece, just to reemphasize the importance of, I think, the conversation we're having today.
How do I follow that? Good evening. My name is Leanne Brewsthead. I'm the Executive Director at the Missoula Urban Indian Health Center here in town, and I've been there about 5 years. And I'm a member of the Crow tribe from southeastern Montana, you know, where Custer got sued. I grew up there. My mother's Crow from the Real Bird family. And my father is from southern Alberta, from the Blood tribe, or as they call themselves, the Kainai. And actually, Annie's grandma used to be my babysitter. You always have history, you know, us Indians were connected some way. And so I'm alumni here, graduated in 91, in the 1900s. I like to say now. Been around a while. And went to OU Health Science Center and got my Master of Public Health there in 94 and started my work in Indian country. I started a little bit here at Salish Kootenai for a couple years, had a baby, so I stayed home and raised her for a couple years. And then I started my career doing community health work on the Northern Cheyenne Reservation. And historically, we're enemies. Crows and Cheyennes don't get along. But they offered me this position, and I thought, well, it's closer to home. Well, I married a Salish man, so I was living in Arlee, and I wanted to go home. I wanted to be closer to home, near Grandma and Mom. And so I thought, well, that's closer than here. I'll see if those Cheyennes will be good to me. So I moved over there, and I kept my stuff in boxes for a year. I thought, I probably won't last a year. I'll just try it out for a few months and see what happens. Well, would you believe it? I made it a year. My stuff was still in boxes. I had made friends. The community was good to me. I actually crossed the street to the other side of town, and I didn't do that for like 6 months, and got to know everybody. And so that might be surprising for some of you to think, oh, this Indian woman was scared of those other Indians. So that fear of others and a different culture, different language, different everything, is shared by all. I ended up living there, or providing care there, living there as working as a health educator for 9 years. I started out fearful and wasn't sure, but in the end, I ended up being there for 9 years. And I still have wonderful friends. They're like family to me. And that's how Indian people are. They tend to adopt you into their families. And that was probably the best experience that I could have had. It was really good. And then from there, I went to the Indian Health Service area office, and I worked there as the health promotion coordinator. And I worked with all the tribes in Montana and Wyoming on health promotion, health education programming. And that was good. I did that for 5 years. And then I went to the Crow tribe, and that process there, I had lost my mother. And that was a really difficult experience for me. I was 43 years old. I thought I'd have my mom forever. She died from cancer, and it I really took it hard. And the reason I'm telling you, it'll make more sense later on down. But in that process, I had no heart. How many of you have lost somebody and then you had no heart to do the work you do? Raise your hand. I was there, and I just couldn't do the work Indian Health Service had lined out for me. And it was a job that my mother really wanted me to do and wanted me to be there. And when she died, I just didn't have the heart. And I went to the chairman at Crow, and I said, it was Cedric Black Eagle. And I said, hey, Cedric, I'd like to come work for the tribe. Is that possible? I'm a Commissioned Corps officer. And he said, I'll work on it, and we'll get you over here. It took about 6 months, but I finally got to go to Crow. I had a lot of support from him and the council. And I worked there for about 4 years. I worked for the tribe. And IHS said, okay, Cedric wants you over there. We're starting the paperwork. Do you know what your job title's going to be? And I said, no, let me call him and find out. So I gave him a call and I said, what's my title? And he said, Executive Director of Health and Human Services of the Crow Tribe. It was like this long, wait a minute, that's not what I signed up for. We did have a discussion and I said, I can do this, this, and that. And he said, that's what you'll be doing, is what you lined out. That's the title. And I, oh my God, how intimidating, right? So I don't think I'm ready for that. And he said, we'll help you. Just come and we'll help you. You'll have help and we need you here. So I went ahead and I went there as the executive, this big long title. And I learned a lot. It was really good experience to work with my tribe and have the support, and figured out how healthcare works, and working with departments, programs, and I had about an $8 million budget. And as time goes on, my daughter was graduating from high school from Hardin, and my husband is Salish over here, and this position at Urban Indian Health Center opened up, and we decided let's move over to Western Montana. I think that'll be good for us. And we'll send our girl here to the university. And so I applied, and I was selected. And at that time, some of you might know about Crow politics. How many of you know about Crow tribal politics and have read it in the paper? When new chairman comes in, there's a big turnover. About 300 employees get let go. It doesn't matter if you're Crow or not. Well, I didn't get let go, but because I'm related to everybody, so I didn't get let go, but the attitude that a lot of my tribal members had coming in was what didn't feel good. And I didn't feel like I had as much support, and this opened up, and I thought, okay, I'll switch gears, and I'll come here. And I came here, so I went down from 98 staff, $8 million budget, down to not even $1 million, and about 800,000 and about 15 staff. I'm like, wait, where's the rest of the money here? And they said, that's it, Leanne, that's all you get. And so it's been all a learning experience to this point in my career, about 20 years now. And that experience I told you about with my mother never really left me. I really struggled with that process. And now I work, throughout, even at the Crow Tribe and at the area office, I'd work with mental health professionals, chemical dependency, and these social service, and all of that began to gel. And then I had students, some of your wonderful students who come to our facility, and I began to see the need for, or this need to change the model of care. When you live in Indian country, a lot of natives in here, if there's a few here, have probably heard so-and-so went to IHS hospital and they don't know what's wrong with him. So-and-so's been going to IHS hospital for 4 years now and they still don't know what's wrong with her. I don't know how many of you have heard that before, even if you're not from the IHS facility or, community. And when I went through my grief, I had physical pain, stomach ache, chest hurt, and the first place I went is where? My doctor, actually, she wasn't IHS. I was commissioned officer. I had insurance. I had insurance, so I went to a primary care doctor. My doctor said, "Hey, I'm hurting. I lost my mom, and she died of cancer. Check me, make sure I don't have cancer." So they did, and they said, "You're okay. You just have anxiety. Let me write you out a prescription for anxiety." And I said, "No, I'm okay." And she said, "No, this will help you. It'll help the process of your grieving." And at that time, I wasn't strong enough to say, "No, thank you." She wrote it out and gave it to me, and I folded it up real nice, and I put it in my purse in the side pocket, and I left. I never did fill it. I just knew that I had to go through this grieving process. So with that experience, I come to be an administrator, and I see people come in and out, and we just prescribe them something or put a Band-Aid on it, but never get to the real source of what is going on with them and their pains and their aches. And like I said, your students came and different people began to talk about this historical trauma, intergenerational trauma, and personal trauma. And I thought, historical, that's over, that's a long time ago. Let's not go there, let's just get well here. And until I sat in on a presentation, several presentations, did I realize how my history has an impact on my well-being today, and my physical well-being, as well as my emotional. And I began to tie those together, and now that's the change that I'm making with my staff and my little center over here. We're real pitiful. We have about 35 centers in the nation, urban centers, and I'm the bottom 5 as far as funding goes. I don't have much funding at all, just enough to do, not too much. And I've had wonderful staff. They sent out letters for donation for dental equipment. I was so impressed with Western Montana and their generosity. We now have a dental suite, and everything was donated to us. Even a chair, somewhere they beat the bushes and a chair flew out, and we had to go pick it up, brand new. And everything, just everything you need. Even a flooring company, I think it was Pierce or somebody, donated flooring so we could tear out. We had something like this, and we tore that out and put new flooring down. That was donated to us for our little dental suite. And so I'm beginning to pull these things together and training my staff and having the courage to change a model of care that will be more impactful for a patient, a client who comes in. And the pieces that we incorporate are cultural pieces in that care. And I have to struggle when I request funding to say that this works, because it's not evidence-based. There's no proof that this works, even though my people used it for thousands of years. I don't have that proof to provide to funding agencies. And so that's where I see my need for assistance from the research community to come in and not tell me what to do, but come and observe what I'm doing, what's working, and help me prove it and have that stamp of approval that these cultural mechanisms actually do work and make a difference in a person's well-being. And so that's where I come from to you to share with, and I'm sure you have a lot of questions for us. I'm probably taking up too much time. I can go on for days, but I'll go ahead and pass it over, and at least you have an idea of who I am, where I come from, and what I need to do. So, thank you.
Thanks. Jason?
Thanks. Well, thanks for having me here tonight. I'm Jason Spring. I'm with Kalispell Regional Healthcare. And it turns out being in a college lecture hall still gives me anxiety after 20-something years, even being at the front. So I'll talk a little bit about what I do. I would maybe argue a little bit that I'm probably the practitioner in the room that's closest to some of like the practical work of what we're doing, because I don't even touch patients. My background is I've been at Kalispell almost 2 years. Prior to that, I was at North Valley Hospital in Whitefish. We affiliated and merged with Kalispell Regional Health System, and so I moved into the Chief Strategy Officer role. I was a CEO for 17 years, 3 different hospitals of varying sizes, but mostly small rural facilities. And so I've been sort of in the practical world of how do you deliver medicine in rural communities and get the resources that you need. And being in Kalispell is probably not the greatest and most challenging place to practice rural medicine. I mean, people kind of want to move there, and it's a pretty nice community. You don't think about Kalispell being just full of health disparities, but there is. There's quite a bit more there than you would imagine. And so my work at Kalispell includes population health strategies, advocacy. It includes pediatrics now. We're building a pediatric specialty facility there that I'm the executive sponsor for. A few other roles, but those are where a big bulk of my time is spent today. And when we look at population health strategies, population health strategies and advocacy definitely go hand in hand today, because as we begin to try to figure out how to better manage our populations, finding the funding and the resources to do that is a challenge. So part of my advocacy role is I serve on the American Hospital Association Board of Trustees and the Montana Hospital Board of Trustees, and I serve on what's called the Small and Rural Governing Council for the AHA. So it's a collection of small rural hospitals across the country. We get together quarterly and we talk about things that we can do to improve healthcare in the United States, and then I'm the liaison to the board for that. So I spend quite a bit of time looking at what we do with vulnerable communities and small hospitals from a national level, but also at our local level when we think about population health. So sort of your statement a minute ago, Chelsea, about sort of where the research falls. Really, to illustrate that, the study that you guys sent us to talk about or to review was published in 2006. It's 2018. It was all true. It was all good data, but the evolution of data and population health has got to move way faster than 12-year cycles, and that's really what we're beginning to see. And so there's some things that have happened over the past few years that you probably have heard physicians and hospital administrators and IT people and healthcare gripe about as we've moved into ICD-10 and we've moved into electronic health records, which are both the bane of my existence every day and also the future of how we get data and how we move into real-time analysis of population health and disparities of care. So when we look at population health, we really think about the triple aim: access to care, reduced cost, and improved quality. And so in the practical world, we start with cost and quality, typically, because that's where we can kind of get the data. And then almost always, that leads us back to lack of access. Where the good quality is and the good cost is, you typically have access. When you don't, it usually means you don't have access to some type of specialty or something. So, and that's almost always driven by social, economic, and environmental disadvantages, to your opening statement about disparities in healthcare. And so, as we get to this real-time data, and we're able now at the provider level to really begin to say today, hey, last month, this is the group of people we saw. These are the people that didn't get care, who are not getting care, or even predictively, they probably won't get care because they didn't get care in this certain population subset. So it's beginning to move us into a much faster pace of how we do business. We have not yet quite figured out how to get paid for that, which is part of what we do in healthcare, is we have to get paid to continue doing what we're doing. The other thing that it's led us to that I think has been good is really looking at what drives health outcomes. So, you probably have seen the studies, 30% is related to health behaviors, like whether you smoke, drink, those type of things. 20% is clinical care, like what we do as hospitals and physicians. 40% social and economic factors, which really gets into this disparities in healthcare and health outcomes. And 10% is just physical environment. Do you have safe drinking water and shelter? So we're beginning to try to figure out as healthcare entities, like how do we partner? Because we don't really think that should be our job, although it sort of has fallen into our lap at times. But how do we partner with other people in the community to help fill some of those gaps? Because it is driving health outcomes, but our business structure hasn't been set up that way as a healthcare system across the U.S. It seems sort of tough to say that, but practically that's just the way it is. And so how do we partner with people like Leanne and you know, and a population that they can help us focus on solving some of those disparities. So just maybe a couple other things I would say about my work at the HA and what they're doing. One is, who knows that it's National Minority Health Month? It's actually the very last day, a few hours left, so we squeeze this in just right, but it's National Minority Health Month. And the American Hospital Association has developed the Institute for Diversity and Health Equity because we realized that when we get outside of the mainstream, a whole lot of bad happens outside of where there's access and where quality and reimbursement lies. So we're really focusing on that, and part of that really goes to, one, educating ourselves about what that means with the data, with real-time data, with educating the field about how that looks, and then really trying to create ourselves as agents of change. Like, how do we make policy happen versus just talk about this at our local level, but how do we really at the state and federal level make policy happen? And so that's been one effort at the AHA, and the other has been what's called the Task Force on Ensuring Access to Vulnerable Communities. This fits right into this. And that really started that task force, and you can go to their website and the AHA.org and find this information if you're interested. But it really started with thinking about rural healthcare, because we're pretty loud in rural healthcare about the challenges that we face with access to providers and hospitals and the distances, particularly in places like Montana that we have to travel. So, but what they found is really the characteristics of a vulnerable community in an inner city urban area and a rural area were not that different. They were very similar. So they put together a task force that looked at both and then separated out rural and urban and came back with some solutions. And I won't take up all my time talking about that, but we might get into some of that later. So at the federal level, we are really focused on this, on disparities. It's not something you see on the news every night that we're talking about as much, but at the healthcare sort of practical level, we're trying to figure out why there's differences and disparities and how at a real-time level can we use data to try to predict and or solve those problems. So I think this is a really exciting panel to have a discussion about that tonight.
Thanks. Annie?
Alrighty, thank you very much. Thank you to all of you for organizing this event and for all of you giving up your evening time with, I'm sure you'd rather be doing Scrabble or something, but but I think for all of us, we're very grateful for you to be here. I would like to introduce myself, Oki Nistantanako Amanisiaki. My name is Annie Belcourt, which is Blackfeet and Otter Woman, and my mom's tribe, the Mandan Hidatsan in North Dakota, is Mittagogay. So I am an associate professor here at the University of Montana. Actually, I'm an alumni as well of the University of Montana. I started here right after high school in 1992, which I realize is like 30 years ago now, so it's a long time ago. When I came here to the university, of course, having lived on most of my life at the, at Blackfeet Reservation, it was definitely a shock. That was the first time I'd have to be in classes with, hundreds of people, most of them non-native, of course. I was usually the only one, actually, but and had never met a psychologist. So my story is that, I came here and was able to meet people who I'd never met before, psychologists, sociologists, all these different fields of science and study. And it was very fortunate for me. And I've always been somebody who's loved reading and loved science, and was able to take physics and chemistry in high school at Browning High School. And that carried through with me, and came here and developed a real fascination for psychology and became a clinical psychologist, speed forward 20 years or something. And I sit on the side of, I guess, the research side now. So I will tell you a little bit about that. I wear a number of different hats, of course, as we all do. I'm a mom, of course. That's one of my primary duties. I have 3 wonderful daughters who are not duties, but they are actually they're really a lot of fun. I have a filmmaker at UCLA, and I have a Chloe who's figuring Chloe out right now, and then I have my youngest daughter, Katie Bella, who's a student over at Paxson. And, you know, I'm so blessed to be here at this university. I'm so blessed to also be able to do research with tribal communities throughout the United States, here in Montana as well. And I've been doing research for about 18 years or so with tribal communities. And as a tribal member, you know, that doesn't mean it's easier or you got secret handshakes or anything like that. Very frequently, it's more challenging because people expect you to, you know, conduct yourself in a way that is consistent with being a member of that community. And so for me, research is something that has been an area that's very hopeful, and that's something I think I try to have be applied and very useful for the communities I work with. And that's been something that is a constant sort of tension, I guess, but in a good way, that I recently had gone home to talk with people, and they're like, oh, what are you here for? And I told them about some project I was working on, and they were just like, you know, it's so great to see you, because whenever you're here, something good happens. Something good happens within our community. And to me, that just really struck me. You know, there's a few times in life where you have that experience of being able to truly translate the powers of education, science, inquiry, all these different things to a community that you truly care about, of course, and you come from. So for me, that's been a real gift. I have been really fortunate throughout my life, not only to be, you know, a learner. I consider myself just a learner, really, but to help people clinically, but also in research, and try to help people think about things and ask difficult questions. So I think a lot of our job as researchers is to be very honest and to think about the things that sometimes people don't want to talk about. You know, I don't take any joy in the fact that Montana has very, very challenging health disparities and needs within our community. We have one of the highest suicide rates in the country. We have a lot of that with our youth, and that's very painful to know and to be, you know, aware that we are not doing enough. We're not doing enough to educate our youth. We're not doing enough to advocate through policy or through education, all these different ways that we can to help our youth feel hopeful about their futures, really. And so that's a real tragic thing. There's a number of different things you could, of course, look at into looking at some of the health disparities that we experience, but at a human level, we have to, you know, at some point take a stand in saying this is not acceptable. And that's been a lot of what my career has been aimed at, is to looking at how do we change big picture situations. Of course, I had worked as a psychotherapist for a while, and that's an important job, a very difficult job to do well, but it's also important to think about population health. So my faculty position is between pharmacy practice and public health. Most of what I do is really public health work since coming back to the university in 2010. I have a number of areas that I'm proud of having done some work on, been able to write papers on ethics. I volunteer for our Blackfeet tribal IRB. I do work on intervention development, and some of my friends and colleagues here, Curtis is here, we have an air quality study that we have two. We have one on children, working with children, one with elderly populations. We do a lot of different things, and I think that's true for all of my colleagues here at the University of Montana. You wear a lot of hats, and you juggle a lot to be here. And one of the things that what we also try to do is really look at culture informing our approaches and our research. And that's something that I'm pretty passionate about, is how do we think about mental health in a way that makes sense to Native communities, that is going to be helpful, is going to be impactful. And those are questions that are very deep questions, but they're also very human questions. They're questions that humans have struggled with throughout time. But I think it's very helpful for people like me, for people like Leanne, for all of the people who are here on this panel to, be able to have that opportunity to ask that question of why and how and what, and how are we going to make things better. And one of the things, just a couple of examples of how concretely this looks. One of our projects we look at the air quality. I'll give a couple of examples. So we had a community advisory board, and that included tribal members and tribal knowledge keepers from a particular tribe in the Northwest. And we talked with folks, and we talked about fire and wood stove. It's a wood stove study, basically. We're trying to improve air quality within homes. So sounds kind of boring, possibly, although very exciting. Learned a lot. Very courteous, yeah. But the thing that was really cool, a couple things, is that we created videos with these communities, and within these videos, we have one that we developed for Western Montana, and it sort of talks about Western Montana being a cool place, and you want to take care of it and take care of your wood stove in a way that reduces pollution. Okay, good things. And with our tribal community, one of the tribal knowledge holders shared with me that he really wanted to include stories from the community too. And so he shared with me stories from their tribe, and we literally had to look up these books that were sort of like the Blackfeet, Grinnell stories or Napi stories. And from that, he gave me permission to use a story about how fire came to their tribal community. And the way that was symbolized was through abalone, the abalone shell. And the story was that, the fire came down from, the basically thunderstorms, lightning, and they were able to capture it within the abalone shell. And so that shell was representative of fire, and thinking about how we as Native people interact relationally was a big part of what we wanted to inform within the video. So then we incorporated that, and then hopefully this will be helpful to people, but anecdotally talking to people who've participated in the study, I think one of the things that's been helpful is sort of we can relate to this. This makes sense to me. And another comment was, we had forgotten that story. We had forgotten the story of how fire came to our tribal community. And so, thinking about research, I think it's a nice example of how we can really complement both our work as scientists, but also the culture, and really begin to face some of these really difficult disparities in a way that I hope will be more effective in helping people have healthier lives. And that's what it comes down to, really, is access. Access to healthier lives, healthier choices, healthier options in a daily way. Discrimination is something that doesn't have to happen in people's lives, and it happens all too frequently to Native communities in our state, as well as here in Missoula. But people are beginning to ask questions about that, and to be curious about how we might be able to change those things. So to me, we're living in a hopeful time, and I think that that's a good thing. I don't think that we hear that message enough nationally, because we are challenged by many things, and I'm trying not to say anything orange related right now, but I will say, in academia, we have this opportunity and this real blessing to be able to ask those questions. And as I said, they may be questions that people don't want to hear or to have asked, but it's our job to be able to say, I think that there's ways that we can promote health and healing, and those things can be done together. So thank you.
Thanks.
Justin. Right. Thank you. Thanks to everybody on the panel. Thanks to everybody for coming out here. Just excited to be here. An event like this doesn't happen all the time. It probably should. But it's not often that we sort of get everybody in the room and start talking about these things and potential solutions to some of these things. So I'm excited to be here. I'm a former Grizz as well, so there's a lot of people in the room right now that I owe a lot to, and I'm happy to be here and try to take part in some of this stuff. My name's Justin Denny. I'm a sociologist and a demographer by training. I've been working for several years now to try and build multidisciplinary teams to try and help understand the social determinants of health disparities. I guess, in short, in doing that, I hope to create opportunities, and opportunities in a variety of ways. Perhaps the opportunity to understand the real health needs of communities rather than assume that I know what they are, and then help us sort of understand and mitigate those kinds of health risks in that process. I want to try to create opportunities for early career scholars and graduate students who want to do research that's meaningful and that helps people, and try to teach them early on that we have to listen to stakeholders and we have to listen to people to understand sort of what we need to be doing. So I think some comments that were on the panel here early on are spot on. Ultimately, I want to create the opportunity for practicing physicians to have at their fingertips the kinds of information they need to provide the best course of care for their patients. I guess in some ways it perhaps helps to tell you how I think about health. And so in short, I think about health not as just a product of whether or not I decide to smoke cigarettes, for example. I think about health as the health and the behaviors of the people around me at work or at home. I think those things are important. I think of health and the importance of the place in which I live. And so, does the place in which I live provide opportunities for or barriers to healthy living? And if you're not sure, if you think that place influences health and well-being, I would say try moving to Houston, Texas. That's where I was for 7 years before recently moving to Washington State. That experiment cost me about 20 pounds and a lot more gray in my beard. So I can personally attest to how place influences health. But in all seriousness, Houston is a really wonderful city, and it's a city that's dealing with a lot of the same problems that a lot of the country faces. And the comment was made, and it's spot on as well, that urban and rural health issues aren't so different. There are some important things we need to consider and we need to understand better, but there are some fundamental things that need to change and some considerations that need to happen in order to sort of better understand some of these things. As an illustration, in studying the health of children in Houston, my colleagues and I found that some kids do poorly in places that we think of as unhealthy places, but perhaps more importantly, some kids thrived in those very same places. And so our conclusion was, well, I think place matters, but it matters specifically to specific kinds of people, and we need to understand sort of both sides of those things to come to a more fuller appreciation. To do the kind of work that I do, I'm really an opportunist. I work to try and unlock the potential of existing data sources that are out there, just not necessarily used or thought of to understand the social determinants of health disparities. I'd like to say that electronic medical records are the wave of the future, but the future's already here. I used medical records, pediatric records in particular in Houston, to understand how kids' health varied across the city and what sorts of things helped kids and what sorts of things hurt kids. That was useful from a research standpoint in that we could identify areas of the city where there were some really stark medical issues, and we could try and go into some of those places and understand what was going on. But perhaps more importantly, we shared that information with decision makers. And currently, right now, infrastructural changes are happening in Houston based partly on some of the work that we were able to do there. So there's really this research side of things, but the research side of things should also influence real change. And I think that we have opportunities to do that. We need to do a better job of doing that sort of a thing. I've been at Washington State now for less than a year, got there this summer. I'm very happy to be back in the Northwest. And I'm trying to scale these kinds of initiatives up to understand the health of the state of Washington, but also the region. So we're hoping to create partnerships across Montana and Idaho and Washington to scale some of these initiatives and understand and build databases to help understand some of the health disparities that are facing people in all of these parts of the country and beyond. As an illustration of the work so far in Washington, we've created depictions of the state of Washington, and many of you are probably familiar with the state of Washington. And we've created, for example, illustrations of major preventable causes of death. So physicians have helped us sort of code up causes of death that are more and less preventable. And as you would expect, the social determinants are really, really related to the most preventable causes of death. And if we look at that across the state, we see that the state of Washington, not surprising, is a story of East and West, but it's also a story of rural and non-rural spaces. And so there are things to be learned in some of those areas. And so I'm working with folks in the Health Sciences Center currently there in the new medical school at Washington State to try and understand some of those things. I guess the final thing I'd say is that, you know, medical records, electronic medical records, are really designed to improve the efficiency and effectiveness of care. And I guess I'm imagining and trying to work toward a world where they provide physicians with not only those critical diagnostic and limited information about the individual, but they provide information about the community in which that person lives as well, so that we can understand some of the things from a community perspective that might be influencing the opportunities and the challenges for healthy living for individuals. If we can do that, I think we can understand health at a population level, and I think that we can understand initiatives that maybe need to occur in specific parts of the country, in specific parts of communities. And we need to listen and learn from people in those communities to understand what's going on and how we can help. So that's what I'll keep working towards.
Thank you, Justin. Thank you all for those really engaging comments, which I think we're kind of eager now to get to some questions and kind of dig into the issues. So let me start with this. To eliminate health disparities, the U.S. Department of Health and Human Services developed a national prevention strategy with several recommendations. So the questions that are below that we'll talk about come from that. One recommendation is to focus resources on reducing disparity in access, something that several of you mentioned, access being the key thing, to quality of health care. So what's being done in this area now, and how can research in particular help that issue? And you don't all need to answer the question, but I'd say let's keep it as lively as we can. If you feel moved by the spirit, jump in, and then we have 2 more questions after this.
I'll dive in.
Yeah.
I'll go quick, and then we'll prompt a lot of fiery discussion. I think Jason's point about the access versus quality is a really important thing to think about in the modern world. I think that there's a recognition that access is something that you can get paid for, right? So there are, I think, companies willing to try to provide access because they know how to get reimbursed for interactions with doctors. But I think the quality access is a different issue. And so I think sometimes we need to, and then also hierarchies of access. So it might be easier to get access to a certain level of care, much harder to get access to a subspecialty level of care. And I think we're just trying to start to figure out how to help people get to the right level of care and the right quality of care and make it meaningful access. I think research has to come into play into helping to evaluate something more than understanding that a touch point with a healthcare provider is not all equal, and not necessarily calling that access and delving deeper into the consequences of that, the behaviors behind that, and the costs associated with different touch points of access to care.
Yeah, I think that fits right into, we haven't quite yet figured out how to get paid for that, to support the work. We're figuring it out, but getting paid for quality would be a great way to do that. The other thing I would mention, and I think the work you're doing at Washington State sounds great. Small rural facilities don't have, we don't have this big staff of IT folks who have great ability to do research and data analytics, if we at all have anything to do with data analytics. So, and so some of that has to come later with MedPAR data or other opportunities, but some of it could be done earlier with the EMRs today, if researchers really, were able to help support rural facilities in accessing that data and making it meaningful and useful to them on a practical level. because we can't today afford, and I don't think in the short run we will be able to afford in a small critical access hospital or a 5-person clinic that ability. So I think that would be a place research could really begin to develop practical solutions that helped us generate that real-time data.
Yeah, I agree. I think there's a question later about this, and I don't mean to skip ahead, but I think the healthcare access issue, especially in rural areas, is also a data issue. And if we can create better ways to create repositories of data that people can draw on to understand these issues and understand where we need to go and how we need to get there, especially in some understaffed areas where exactly, I mean, it's not just about seeing somebody, it's seeing the right person, right? I think a lot of this comes back to a data issue. We need to get better at that. If we can get better at that, we can come up with better solutions.
So I guess my perspective, as my background, I'm not an administrator and I don't look to make money. So I come from a different perspective. And so that has nothing to do with my observance of my population having access to care. When you look at the people who don't have access to care, really looking at them, not trying to entice them, but look at what their barriers are. So for example, I have, say, a WIC program. We get lots of numbers and suddenly they dropped. They just dropped and we're like, oh, access, what's going on? How come they're not accessing this care or this service? Come to find out, a lot of our young women were smoking pot or using some kind of drug, and they were afraid when you come in to get WIC, they check your blood for it if you're anemic. Mm-hmm. And they were afraid that if they did that, they would find out they were on drugs and they'd go to jail. And so they were afraid to come in to get that done. And so we needed to educate that population so that they could access care. So a lot of you are very intelligent, have insurance, and you probably have who has problems accessing care right now? Raise your hand. Almost nobody in this room. You're intelligent, you know what you need to do for screening, for prevention. So it's not, so my piece is looking at the population and why they don't access the care and their fears and their lack of knowledge and a space that's comfortable. And so one community changed this, their office into this house and had some couches and made it very non-threatening, not so formal. And then a lot of these young women started coming in. They didn't feel so threatened because then somebody went out that, so for another example, we did HIV testing in Lame Deer, Montana. I didn't do it, nor did my community workers do it. We had young people from Billings come in who had piercings here and kind of shaved head here and earrings and tattoos, and we had them come into Lame Deer on Saturdays to do testing. Oh my God, we tested 80 people. Indian Health Service would test 8 people a year for HIV, and we got 80. Thank God none of them were positive. But so the population, the group of people that did the interaction, they weren't threatened by them. There was no judgment. That access to care for me has nothing to do with money. It has to do with that population and how they perceive care and how those barriers. And so that's what I look at and what I see, so that it's a comfortable space and non-judgmental, and that there's accurate information going out so that they will be like you, who will then say, this is important. I need to go in and get this done. So that's a perspective from me.
Great. It's a really valid perspective too.
Right.
That
we can build really beautiful facilities that some people aren't comfortable walking in.
That's right. That's
Or families can afford, for kids, that's accentuated too, right? Because that's the child, the parent, missing work, that, how do we meet people where they are, not just say, hey, we're here, you had access.
Yeah, I would add to a couple things. One being.
Thanks, Annie, for coming.
Hey, it's good to see you. So speaking of Annie, though, like the programs that help train new people in, I think, are incredibly important. We have more Native health professionals, because we know that the health disparities in Montana are primarily faced by Native people. Some rural, of course, as well, but like a lot of Native people face some pretty significant challenges. So getting people trained, it doesn't have to be at the doctoral level. Some of them are becoming social workers or educators or peer educators. A lot of the social determinants of health, of course, poverty and different things of that nature. But it doesn't take superhuman skills to change some of those things. You can volunteer. You can do things that, as community members, that can help to elevate the health of all of those within a community, and that those don't all require that you have a PhD. So one of the projects we're working on is a narrative exposure therapy for PTSD, and it's a trauma therapy that was designed by German, actually, researchers who are working in the Congo so child soldiers they were working with who had a lot of exposure to significant trauma. And what we're doing in a couple different tribal communities is adapting that, and it's a short intervention, and it can be done by people who are like paraprofessionals, who are good listeners, who can actually help people, and it's been shown to really decrease PTSD and things like that. And so some of the things that we've been talking about more the physical health side of things, but the mental health is really a lot of the driver of a lot of the physical health disparities that we see, with there being such huge comorbidity with depression and cancer or all these different conditions. So being able to really look at logically too, what are the ways that research can complement some of those findings and get people services that they may need in a way that's more appropriate or accessible. So some of those things are some of the things that we've been trying to do. One of the projects, or a couple projects I've been involved with here, iFarm, which is, I'm gonna forget what it stands for, but it's rural health screening. And we've been able to partner and go to tribal communities and have 150 people screened on their A1C. And we've had people, not know they were diabetic who came to that screening, or not know that they maybe have osteoporosis, and then have health counseling real time to be able to say, oh, okay, I can do something about this now. Or that a lot of people came back pre-diabetic and things. So those are some examples. There's many ways that we can think about research creatively to not only help increase access, but to be more thoughtful about how we are intervening with communities. And part of that is Native scholars and scholars development. And the university has, we've graduated over 60 pharmacists, Native pharmacists, in the past 30 years or so. Similarly, we have physical therapists and people that we know will go back into the community, psychologists, me being one. So some of those things I think are critical to the health of communities and to rural communities where it's hard to recruit people sometimes. I mean, we had a state of emergency kind of winter in Blackfeet this year and haven't even been up there since. But, but seriously, like we lost 3,000 cattle, and so this can have some impacts in terms of health over time. And the more that you can invest locally within the community and the human sort of social capital of a community, that can help as well.
Okay, another recommendation was to standardize and collect data to better identify and address disparities. So the subsets of this question are, is this really taking place? How does the data get accessed? And what are the real problems? I think you alluded to this, Justin.
So it's a great question. Is it taking place? Sort of. And I say sort of because it's sort of, it's not systematic. So there seems to be a lot of initiatives So one of the things we're trying to do is get the initiatives to talk to each other. But there's a lot of initiatives, regional initiatives or site-specific initiatives that are trying to work with and create repositories, essentially, of electronic medical records to try and do some of the work. There's a lot of concerns with that, very rightfully so. So there's a lot of confidentiality concerns in terms of making those things accessible. And I think one of the solutions is to keep the data where it is, but make it available in ways that we've done in the past with survey data, for example, to anonymize data and still make it available, make it useful to not only researchers, but communities and clinics, for example, that are needing to deal with the issues that are particular to their particular clinic. So I don't know, I hope that we're moving in that direction. I think that we are. I think that it's stalled somewhat, as has a lot of things. But I think it's, my bias is clear. Being a data nerd, I think that kind of a lot of the solutions are rooted in some of this, and that some of this is taking place, but we've got a lot of progress to make in that area as well to try to make it systematic.
Yeah, unfortunately, the design, as I said earlier, for healthcare is to code to get paid, not code to develop research. Although it's got, I think, better, but that incentive, if we had more alignment there with quality and understanding what we wanted to do with the data, other than just get paid by it, might make more sense. Some of the concerns I have going forward that I think researchers really probably should weigh in earlier rather than later in two areas. One is we think about moving to more capitated payments so that we're paid a flat amount to care for a population. Now I don't have to spend my day coding. I get to take care of patients. You lose a lot of potential data. And the other is in telemedicine, because a lot of things that happen at the face-to-face visit with our own site, we're coding to get paid there. I have some concerns that as telemedicine becomes cheaper and easier, that people will just pay a flat rate to pay for a service for primary care, that instead of it going through their insurance. And if it doesn't go through that route, then you're going to lose access to research data in that. And so I think we probably need to spend some time now thinking about that before we realize we have a data lag of a few years where we didn't think that through. So.
I had a question as I listened to you speak that EMR has changed a lot, but the question is always, is it generating data in a form that's useful for teasing apart the issues? So I noticed you talked about the fact you saw a change in the population. The question is, what are the barriers that are causing this? Mm-hmm. And I wonder if the data is coming in a form where it allows you to really probe it and ask those questions. Because if we get really far down the road with EMR data and then we realize we're missing some key things, we have a lot to make up there.
Yeah.
I think we know. Yeah.
Oh, go ahead.
No.
I'm sorry. I was just going to say quickly, one of the problems is it's not in one form. It's in many, many different forms, and that creates issues as well. But
Jason just made a great argument against himself too. Did you hear him? The data capture and the thought that EMRs have been I think you said were created to make doctors' lives more efficient in something else would be a highly contested statement from a practitioner perspective as well. But I guess we're saying we're grateful for the fact that some of the things that we have are now in a form that we can do some retrospective review and we can start to put together pieces. I think we're also saying this was put together in order to facilitate billing in a fee-for-service model. If we transition out of a fee-for-service model, or if we transition for good or bad reasons, we will lose what we have now because the EMR wasn't created to ask or answer important questions about why people were there. We're trying to mine that. So it is a great thought. How do we can't go back and answer questions that weren't asked. And so
sure.
there is some work within like the community health center world to standardize what is it that we need to know about people coming in to specifically then understand health disparities. So those data sets are trying to be created. Again, sort of you run into the technological walls of actual interoperability. And the other piece about the data that's so interesting, exciting, but difficult is it's not just healthcare data that we need, right? Sometimes it's school attendance data that actually is going to be the powerful piece to get the funding that we need at the legislature to inform the fact that access to this type of healthcare is actually really matters to getting kids to go to school. And it's the sick kids who aren't there. And then we have a different funding stream, or we have a different legislative argument to be made. So there's lots of hope in data, but we are using imperfect forms that were created for a different reason. If we move away from that reason, then we don't even have those forms, and I'm not sure that we have a super sustained effort around healthcare disparities informing the next round of coding, because if you told a bunch of doctors you don't have to do it anymore, they'd stop right now. And so how do we, again, align incentives? How do we infuse the importance of them taking the time to record that information with their incentives and the incentives of asking good questions in the future? And I don't know if it's that.
Yeah, the other gap in using the EHR data and claims data is, I'll use it as a time to pitch Medicaid expansion in the state of Montana, not being sunsetted.
That's a good one.
But when people are not in the system and they don't access care, and we have no data on them unless it's mined through something totally different. So thinking about how we try to capture that, I think, is important as well.
I just wanted to add a couple things. I mean, when you talk about federally funded research and things and data, so people have really tried to encourage some of these methods of kind of standardizing data, but it does get much more complex when you're talking about Native communities for many reasons. One of them being, sovereignty issues, and that Native tribes are sovereign nations or communities that have a right to control access to their data. That's important for many reasons. The Havasupai case being a good example of misuses of data that have damaged communities. And there's others, like the Barrow study and others. But I also, there are potential problems too when you talk about cross-cultural measurement of pathology. That could be psychopathology or different things where, are we really measuring depression? Are we really measuring intelligence with the measures that we're using? For example, the primary intelligence measure that we have is the WISC and the WACE. And one of the questions on that is, who is Columbus? And the way that it's scored is that if you say anything other than the person who discovered America, your score is 0. So if you say he's the person who enacted genocide and this, and all these other more accurate characterizations, that you're ranked as less intelligent. So if we think that we have the gold standards of these different construct measurements, we probably should ask that question of whether or not that's culturally, transportable between different communities and things. There's some things, of course, like cancers and things of that nature, but even that, you're going to have different things that impact exposures in the environment that could also impact culture. So, that's some of the cautions of making everything uniform and a uniform approach to science is some of the people who maybe don't fit within our definitions or expectations of that.
I'd like to just follow Annie, and that was my concern, that word standardize. I was like, oh no, we don't want to do that. Just for the very reasons that she just alluded to, is our perspective of the world. And how you ask the questions, and are we even asking the question? Are we asking the right question? And the ACEs study, I think, is a great example. They asked particular questions, trying to figure out why people couldn't continue losing weight and maintain a good healthy weight. And in the end, it was the most common. It was trauma related. The more trauma you had in your life, that was scored. And the most common trauma that occurred was sexual abuse that came out. And that was probably something they weren't thinking that they would find. And so that when you talk about identify and address disparities, not everybody's on the same page, and I'm sure there's a lot of different perspectives. But mine, as a Crow woman living in Montana, looking at my Plains Indian tribes, I've come to realize that It's not just focusing on a particular disparity of, oh, they're diabetic, let's just try to get them to exercise and eat good. Oh, they have cancer, let's just have them stop smoking. And in the end, if you dig deeper, it's that very word of trauma. Some of life's experiences that are really hard, we don't have the right coping mechanisms that then, like I shared earlier, that result in physical ailments and diseases. And one thing I want to share with you, when you work in Montana and you're working with the tribes of Montana, how do I say this? Our historical trauma and its impact is so important for you to know and understand when you talk about these disparities. How you provide care for them will really change, and that's what I'm really pushing, to have the courage, all of you, to have the courage to change the system, and that it can start here in Montana. It is happening all over the country to be trauma informed, but there's so much more to that word. And just a little history for you to understand. The tribes in the last 200 years, we were hunted, killed, whole families destroyed. And then, how many of you, so our religion, you call it religion, that's how you identify this particular way of having a relationship with the Creator. It was against the law for us to practice our ways. Do you know up to what year it was against the law?
1974.
Almost. 1978. It was against the law for Native Americans to practice their, what you call religion. Okay, so think about that. That was till 1978. Now, our whole identity as a Crow, we don't separate religion and being a Crow. I call it spirituality. There's a difference between spirituality and religion. Spirituality is a direct relationship with your Creator. Religion is man-made to control other men with fear and the devil and hell and all that business. That doesn't exist in our culture, or as a Crow, that doesn't exist in our world. And in our process of being a Crow, there's a lot of healing mechanisms and a way of being that is really good for health, well-being, that you'd identify as your mental, spiritual, physical, emotional. All that was entwined of being a person that couldn't separate it and just go on Sundays at 10 o'clock, and practice that religion. It was entwined in our being and everything we did. And when you tear that away and say it's against the law, you have people that don't know how to be. And you need to understand that. Those aren't separated. That is who we are and how we practiced and how we were, each tribe, and how they had their relationship with the Creator. And that was how we were maintained our well-being. And so I just wanted to share that with you so that you understand a different perspective of our reality and our world and our way of being. A young man, one of your students, gave a presentation. I'm a fluent Crow speaker. I grew up speaking Crow. I didn't learn English till a couple years ago. No, not too long. Oh, well, a few years down the road, I learned to speak English, but my first language was Crow. My grandma wore moccasins that she made. She wore a cotton dress, and she wore a scarf. Nothing was store-bought. In the winter, she didn't wear a coat. She wore a blanket, a Pendleton blanket. And that was my grandma. She wore a shawl in the spring and summer, and I would go with her places, and I would hold her fringe and follow her as a child. And that was my reality in my world. And we see things differently. We live in a culture, we have clans and we have relationships, and we see the world in a different way than you do. And that's probably, how many of you have left the country of the United States? Raise your hand. That's good. So you know there's a different way of thinking and doing things and how you see the world. And that's how we are as Native people. And I just wanted to share that with you. When you look at this, identify and address disparities, and that word standardized data, and are you asking the right questions? I'll tell you right now, no, you're not. And how do you ask those questions? But to create more, like Annie here, to create more of our scientists that come from our world. And that's provide scholarships. Get them in here and get them through this, and they will bring you a perspective. I feel like I'm really, really blessed to have the teaching of public health in my background, and being a Crow and pulling those together to have an impact in Indian country and having the courage to change our systems. All of you need to have that courage to change, because right now people are dying right and left. They're shooting each other. There's all these drugs. And so somewhere, and you know the definition of insanity, right? Doing the same thing, expecting a different result. So we need to stop doing the same thing and start doing things differently. So I just wanted to share that with you. Thank you.
Thank you. So I think you have one more question. What I'm going to do at this point, I'm anxious to get opened up to the floor. We can see the question up here, and it really, I think that last bullet is the one I think is most interesting. How do researchers ensure their work informs practice and policy? And that's been touched on just a little bit, but I think I'm going to just say, if you want to make a few comments, but also from here forward, I'm not going to say anything. I want the folks in the audience to be able to ask you questions.
So folks have a question on the microphone.
Okay, and there's a microphone up here.
What we've talked about here today, and most of the narrative on a national, even international level, is the issue of access to care. But the disparities are large, but even larger are the disparities in outcomes between communities. And of course, they're linked. You know, the longer you wait to go have that tumor looked at, the least likely you're going to have the outcome you would have had 2 months before. And I think we're making some headway there. I noticed that some of the people that pay some of the bills ding you if the person comes back to your hospital within 30 days with the part of the same complaint from the same procedure. But I think we've got a lot more to solve than the access to care. But if we do solve that, the outcomes, some of them will not disappear, but vitiate a little bit and take care of themselves. And I think we need to spend more time, we started to, as I say, spend more time on disparities in outcomes and then tracing that back as necessary to access. But it's not just the disparities in access, it's the time itself is an issue. Reaction, please.
That's just cheating. You just made a comment. Reaction. We all saw it. No, I think to all of these points, it's all interwoven. And working backwards with cultural competence and with an awareness that it isn't just getting people in, or that showing up doesn't mean people will want to see you. Listening hard. And aligning, trying to find ways that when we're asking questions, we're thinking about how should we find an answer that we think is useful, that we can continue with that in the future. I think that everyone agrees. I think it's amazing headway in the perspectives here, and for you guys as researchers. I don't know how hard it is in the research world for you guys to write the grant that says I'm going to go listen really hard. Right? Like, I don't know. It'd be interesting to hear from some of you, and you have that perspective on, is there space for you guys to flourish as researchers in a way that is open to the real complexities of cause, if we're working backwards from outcomes in a really open way. I don't know. Is it? Is funding available? Because that comes back to the practicality.
That's a great question. I think it depends on sort of the mechanisms, of course, and things, and the person writing the grant making a story that is compelling and that people want to help solve that story. So most of the research that I review and am aware of is multi-methods research. So you have quantitative aspects, but then you also have qualitative aspects where you're asking those questions and listening and trying to be very thoughtful about, does this make sense, and those sorts of things. And so there's much more of that now. We have a number of mechanisms that are active on our campus and others that are specifically looking at towards some of that. But you do have to tie it to an outcome. You do have to tie it to some, typically a problem. We just had some speakers come from Alaska, and they gave a really great talk about a suicide prevention program that they were doing. And it's been funded for 30 years, I think. And the interesting thing with their project is they don't actually ask about suicide. They ask about all the other kind of protective factors and things. And so, of course, they go back to DC and they get dinged, about that. But it comes back to the issue of we don't know enough about health, and our vocabulary is not adequate to really capture health and wellness. We're really good about slicing up problems, but not so much to the health issue. So I think in terms of outcomes, I think that's a way that we can grow as a field, is to really look at some of those other questions.
Yeah, mine's actually more of a statement as well, and I think Andy sort of answered it. If you look at where the funding is, particularly the federal funding, the external funding, it's not related to practice and policy. It's solving individual problems, health problems, biomedical research. Except for the Bakori funding, there is almost no funding in these areas, and so researchers tend to follow where the money is. So unless the feds decide this is an important area, it's not going to be a lot of research done in it.
I do think there is an opportunity for partnerships in health systems. I mean, as I mentioned earlier, with rural facilities, but health systems, because we are moving, and I hate to sound harsh about payment, but access is provided by payment. Like, that's how we provide access to our communities, by getting paid for that, right? It's just the facts of it. But as we move to being measured for quality, which might be readmissions, it might be that diabetics get their care, and that we know that they're not getting their care, and we help coordinate that care. I mean, there's all sorts of things that complain. But I think there's opportunity for researchers to come to health systems and say, you have all this data, you don't have analysts, we would like to do some research. I mean, maybe there's a partnership there that would allow us to, you help us mine our own quality data, and in the process, you do some cool research.
But how are you going to pay the researchers to do that, because you have no way to bill for that?
Well, as we get, if we're successful in improving quality, then there is potential savings back to us that we get paid. And so in some way, I mean, maybe researchers have some risk with us, because that's what we have, is risk on it. And maybe there's some ways to get creative with that would be, I think, of interest to us.
Yeah, I think it's a great point. It's a great discussion. I mean, it's kind of what we're trying to do right now in Washington. And we're coming up with all kinds of potential solutions. Whether any of them will work or not, we don't know. One of them is to look to, there's a surge, and a needed surge, in foundations and nonprofits to fill really important holes in funding. NIH has a model, and that model doesn't necessarily play well with us trying to figure out what people actually need, and how we can, in the process, understand health disparities better, and maybe even provide back to our clinical partners information about their populations and what might actually help them fill a hole that is their biggest problem. Foundations like the Robert Wood Johnson Foundation are all about that. And they are trying, they're appearing, they're seeing a gap that needs to be filled, and I think they're not filling it all, but there's opportunities outside of federal sources that are perhaps areas that we all need to think a lot about. We all need to collaborate with perhaps not one entity, but with several to try and piece together projects. And there's risk on the researcher side of working with these partners to try and establish this before we have many dollars to actually do the work. But it's a great discussion, and it's, I think back to sort of the access versus outcome. I think 100% I'm an outcomes guy. I've learned to talk about it a little bit better when I'm around my physician friends, because I don't think access doesn't make you sick. All these other things make you sick, and so focusing on outcomes and things is important, but it also doesn't have to be distinct. Outcomes and access we can get there in both ways if we just start to ask the kinds of questions and try to understand these things from a ground level and up to sort of entire population. So it's a great discussion to have, and I think we're trying to be as creative as we can, thinking about solutions and where they might come from.
One of the people that I reached out to when I was coming was the woman who's the CEO of Headwaters. So to your point, I won't read all of her bullet points, but they would be every bullet point that we've said. So I do think that emerging foundations, healthcare focus, and this is a local reality of an opportunity. Everything that she wants to see is participatory, community-based, clearly communicated, could be put into practice quickly. Look at race and poverty. These are the drivers of health. And so outside maybe of traditional funding structures that are harder to change, we do have some very specific local examples of opportunities to at least get things off the ground. And maybe those provide the seeds to, maybe you find in that the piece about diabetes that allows you to be tricky and pull that into the NIH grant that was maybe less thoughtful at its inception. But at least Brenda completely agrees, if that's helpful.
Hello. My question is a little bit on a different topic about the slide before. So I'm coming from a research policy perspective, and one of the reasons for standardization is to have some common measure across populations to actually identify these disparities and hopefully address them. But Leanne, you made a very compelling reason against that, and I totally respect that. So my question for the panel then is, how do we then, if we want to have culturally appropriate measures of the same or different constructs, how do we do that? How do we measure disparities across different cultures that might have different goals, different values, and really different perspectives of living?
I think Chelsea said it earlier, you have to listen real hard. I have people that will come in and man, they'll talk for the whole hour. And they didn't learn anything about me and our people and our history. And so you have to learn to listen when you go in. That's number one in public health. You go to where the people are in their well-being and what's important to them to make those steps towards, overall well-being. And so you have to know that not impose your value or your view when you do your research with a population that's different from you. You're really going to have to do some homework and understand, and then be able to listen, but also be able, what you're hearing, does it make sense to you? And if it doesn't, you need to go further and really take time to understand. And sometimes you'll learn more than the natives themselves. Because a lot of times they may not even ask a lot of the deep questions that you as a researcher might come to ask. And I don't know, does that answer your question?
I would take a shot at answering that too. And I thought what her statement was just beautiful about, how we in a health system totally, we're thinking, no, just take the EMR data and tell us what, comes out of it and how to fix it. I thought we'll never get that out of the EMR data. But one of the things that I think standardized data allows you to say, all right, here are some populations that that are different. So now we got to go look at those. And that's one of the things the AHA's focus on equity was. They ask each hospital to pledge to go just look at one population and see what's different. Whether it's veterans, whether it's Native Americans, whether it's, you know, whatever you are in the community, pick one and let's just focus on those communities on one element. Go listen, go ask the right questions, dig in, see if you can move the needle at all with the population. And I think that's one way we have to do it. We got to start with like, okay, where are there differences, and now let's understand them. And listen a lot.
I would go get kind of techie on you and say I have hope for artificial intelligence, because one of the tensions around standardization of data is it a structured data field or a free text data field? And you know, I've been working on building software, and at every moment you make a decision between, do I let this person tell me their story, or do I force them to pick one of the 4 options that I think would be a good part of the story? And I secretly so maybe your next project, could someone apply for a grant to throw some artificial intelligence tools that are off the shelf now, right, at some unstructured data fields in an EMR? And because maybe we're moving out of an era, maybe we're in like a technological doom place where we all use drop-down menus, but we're going to be able to listen, and maybe computers are going to help us do that at scale. I don't know. I might be a little bit too optimistic, but I do think natural language processing holds some degree of hope that we're going to get away from the only way we can understand a data set is from a drop-down.
So the data that we just purchased a
Maybe not,
company called
but-
Optum. No, it uses natural language processing to. I don't know how good it's going to be with AI yet, but
It's not there, but I kind
it's
of hope
at least I think a start. You know, to begin thinking about that. I think that's a great idea.
Just sort of from social science sort of fields, some of the things that we can do concretely is looking at validity studies on different measures. You can look at the psychometrics of things. You can, if there are things that are discrepant, then you can start to do more of an in-depth analysis in terms of, you know, does depression look the same across different populations, for example? And if it does, relatively, then you can use this pretty similar, you know, PHQ-9 or what have you. And there's a pretty strong rationale for that. So part of that is just doing, like, you know, the basic psychometric, you know, analyses that we do to make sure that whatever we're trying to measure, we're truly actually near the mark at least. But then some of the bigger questions are things that, you know, do require a lot more thoughtful approaches and a bigger lift in terms of the analytic power that you bring to a project. So, but it's, you know, these are human people, so the most complex structures that we have to date, I think, arguably. But so it's not like there's going to be a perfect recipe to, you know, I'm going to solve depression for all human beings. Although UCLA, as an example, they've really dug deep, and they're really looking at depression specifically, and have a very ambitious goal of I think, reducing depression by half. And they're trying all these different things. So there's ways that people can work together on a really big problem, like depression or what have you. So there's some ideas and thoughts.
Hello. I have 2 comments. I'm a foreign-born intercultural researcher, and I've been at the university for 30 years. And I have rarely, if ever, seen a panel this diverse. And it's just wonderful to see different perspectives represented, and different approaches and different viewpoints. And I thank you for that. That's a wonderful opportunity. The other comment I'd like to make is having researched and taught and try to understand the importance of intercultural competence. Leanne's points earlier were, I thought, so important to understand that there is more to understanding how people function than the way that we seem to subscribe to. A way other than our own, to sort of look at traditions and customs and values that may be different, and that may aid in a process. In your case, it was healing and understanding a certain healing process. It may be a process in education and cultural adaptation in whatever. I think it's so important, and then Annie, what you said too, it's this intercultural competence that I think is hard to grasp, but it's a very important aspect of, I think, reaching the sort of, or closing disparities or coming closer together in general. Thank you so much for sharing that tonight.
Thank you.
And I'd just make one comment there too as well. I think the diversity of research teams can't be overstated. If we're going to understand health in different communities, we need a diverse research team to try to understand some of that. And so yeah, it's a great comment.
Hi. First of all, thank you guys so much. This is awesome. So forgive me, I haven't fully thought through this question because it just came to me kind of listening to this discussion tonight. But the topic of payment has come up again and again, and how that affects how we gather data. And we've obviously been talking primarily about the United States. And I'm curious whether countries with single-payer healthcare systems face these same challenges that we face with data gathering, and if we were to move toward a single-payer healthcare system, how that might affect the research and the ability to do that research.
So one of the big issues not only is payment in the moment or gathering data that we're gathering data so that we can submit the bill, essentially. The other really big piece that single-payer health systems is that the person who's paying for your healthcare now is not the person who's going to be paying for your healthcare when you're 50. So there's not just a data component, it's an alignment of an interest of the party who's paying now with the party who will pay later. And I think that's one of the other uphill battles that when you unify, if the same person who's worried about whether you graduate from school, made it to school today, are going to be a part of the workforce later, whether you're going to get a chronic disease at a young age, if their incentives can align throughout your lifetime, then they will solve for understanding whether they can do something less expensive now. And I do think we see countries that unify those efforts, not only in their ability to understand, but in the incentive structures of the payers, are doing a better job of setting up their populations in a holistic way for a healthier future than we're doing, not only in our data fragmentation, but in our incentive fragmentation with payers that don't carry you through your lifespan.
Just something for you to think about. I just sat in on a presentation in the last couple weeks, and they showed how the United States, compared to all other countries, we pay the most and we live the shortest. We pay the most for our health care, and we live the shortest out of all these countries. And the one that pays the least and lives the longest was Japan. And our challenge as the United States is we have so many different cultures, and Japan doesn't. They're all Japanese, you know, and so they all understand and know and practice that well-being, and so they don't have to pay so much for their health care. That was like blew my mind when I saw that. We're the richest country and we pay the most, but we live the shortest. And this country that doesn't put as much money into their health care live the longest. So then that makes you think about the environmental factors, protective factors, all these different things. If we truly are wanting to make a difference in the disparities, you know, we need to look outside of ourselves, see what's really going on, to open our eyes, to see what's keeping other countries and their whole country healthy. Guess what? When we get there, guess who's going to lose a lot of money? The healthcare system and insurance. So that's maybe one.
Yeah, I would add two thoughts to that. One is that what we code with in the United States is ICD-10, International Classification of Diseases, 2010, which we didn't put into place until like 2015. Ideally across the country, or across the world, we've tried to get people, and Justin would have to speak to what countries do that and don't, but most developed countries are trying to move to the same classification of diseases. But I think the point of where we spend more, and this could be like a whole nother night of discussion on the difference in cost and the difference in social services by countries. Because when you look at disparities in care and the social determinants of care, those countries that have a low health care cost keep people from getting sick because they provide social services that we choose not to provide, particularly across cultures. And so, Justin's probably the expert on that way more than me as to what the data shows in other countries, but that tells a very important story, to your point.
Thank you.
Other questions?
I was going to say, I wonder, given the hour, we don't mean for this to end abruptly. I think we want to allow. Do you have another question? Yes. Okay.
I'll make it quick.
Maybe the last question, and then we'll open it up for just getting together and.
All right. So I've been working about a year with a researcher here at the University of Montana. I've been doing the data collection, and it has been really hard. And we were working with at-risk youth across the state of Montana from 4 different sites. And a lot of times we're dealing with traumatic subjects. And when we've been trying to figure out why things are being measured differently or not being measured at sites, the big national discussion was, you're bringing up with youth these traumatic experiences again after they've already lived it, and they're trying to become better in their lives. So how do we deal with that data collection? Because this is a program evaluation. We want to make sure that going through these programs, it's effective in these communities. So how do we deal with that data collection? Thank you.
So it's the what now. We know we want to kill ourselves. Now what? We know why maybe. That question of we're utilizing some models from California, resiliency skills you can use right here and now, and not have to wait or do anything. I'm kind of in the here and the now. Let's help the people right now. And so that the implementation of a skill building is so critical, and that's what I'm seeing is so needed. And so and we started that, and we see really great results. I told you my daughter's graduating. One of her, in community health, one of their projects they worked with kindergarten on resiliency skills, and the simple coping mechanism they taught them was breathing. And they labeled them 4 different ones, like flower breathing and puppy breathing or something. I can't remember. They were real doable, and they were attached to different feelings that they had. If you feel this, then you can do this breathing. If you want to go to sleep, do this breathing. And that simple, those things, those skills that we begin to teach our children early. And then those children, I happened to be 2 weeks later, I was visiting with this lady, telling her about being able to teach the here and the now, something that will immediately provide, so they don't have to relive a trauma or anything, but to self-soothe. And I was telling her, and she said, "Oh, my child must be in that kindergarten class, because he came home and had me and his dad doing all this breathing, and now we're all doing it." So this child taught the parents some self-soothing skills. And so I hope that helps,
It sounds like training we need to actually get to the field worker so that we can educate people in this.
I have one.
And then begin to get that data if that's working. Mm-hmm.
You totally opened a door I was not going to walk through. I have one quote by a sociologist in my entire life that I found so inspiring. And I'm sure because you guys are the social scientists, it could be I don't know if he's a good guy or a bad guy, so you can totally hold me accountable to this. So no one. But I had it on my notes because I think what you're getting at is we're trying to get information and we don't know if the gathering of information is doing harm or not, right? So you're being forced as a researcher to step back and question your methodology, and you're learning something. Maybe not, you don't know, right? But you're being confronted with a challenge as to, is asking the question doing good or harm? Is that kind of where, and how do we know that? So this is my favorite, and then, so self-indulgent, I'm sorry. Stephen Ball, is he good? No? Medium? Okay. But he says, placed outside of mastery and victory narratives, inquiry becomes a kind of self-wounding laboratory for discovering the rules by which truth is produced, attempting to be accountable to complexity, thinking the limit becomes our task, and much opens up in terms of ways to proceed for those who know too much and too little. But I love that self-wounding laboratory idea. So we maybe set out to ask one question, maybe we have a different question that needed to be asked in that process. Anyway, so there you go. Stephen Ball, the sociologist for the social sciences.
Well, before we finish up here, could we have a round of applause for this excellent panel and their hard work?